So what you're going to hear about today is how some of our core capability has been reimagined and repurposed in order to support health and care systems through this very challenging and testing time of the pandemic. We have, as an organisation, provided absolutely comprehensive support, and perhaps you will hear some surprising things about what we have done. During the time when we were all locked down last year, we started thinking about what might be needed to enable the UK to end restrictions and to leave lockdown. And we concluded that there were probably two sort of core areas. One was really good contact tracing, and the other one was the development of vaccine and its widespread rollout. And so, as well as doing all of the business as usual type of vital support projects and programs and, you know, running control centres and all the rest of that kind of stuff, we started exploring with some of those key organisations whether we could contribute to track and trace. We had wide-ranging conversations with the Association of Directors of Public Health, with the local government association, with various sort of people nationally. And I think it's fair to say that we could see that this was rapidly going to become a crowded space. And so in the end, we withdrew our involvement from that. And as a result, track and trace, or test and trace, was set up, and the rest is history and all of the noise that has been associated with that. But at the same time, we were also thinking about whether we could leverage the capability that we have in our child health information service around the management of immunisation. We are the largest provider of CHIS services in England, and that means that we are responsible for making sure that children from 0 to 19 receive the immunisation that they should receive and the checks that they should receive. We started to think about whether we could leverage this and take forward a proactive offer of support to NHS England to say, actually, we think that we could start to prepare for a large-scale rollout of a vaccine. And you will very shortly hear from Sue Trinder, who will tell you about where that went to. But basically, from those early beginnings back in March 2020, by July, we had been asked, in principle, what was the art of the possible? Could we start to think about rolling out a large-scale, national, for the first time, immunisation management service, initially to handle the biggest ever rollout of flu vaccine, but obviously with the view that as and when vaccines became licensed for COVID, that we would be ready to do the work for the COVID immunisation programme. So there you go. That's enough from me for now. I'll hand you over to colleagues who will tell you all about the surprising things that SCW has done.
Good morning. I am going to talk you through the Immunisation Management Service, otherwise known as IMS. IMS ensures the right people are given the opportunity and the support to access the right vaccine at the right time. Our service is digitally enabled. It supports the planning of vaccine delivery using the Joint Committee for Vaccination and Immunisation Guidance and local intelligence. We are able to ensure that we align demand of individuals who want to book their appointments with the capacity. And the capacity includes the vaccine supply. It includes the human resource who are manning the mass vaccination centres. It also includes 119 who support individuals to make their vaccination appointments. We are able to prioritise people at risk for vaccination invites. We receive on a daily basis information about individuals with relevant underlying health conditions that make them more at risk of COVID, and so we can prioritise them for a vaccine. Some of the ways that we have been able to support the planning, and an example of that is at the beginning of the rollout of COVID vaccine. It was the JCVI guidance said that the elderly population had to be vaccinated first, and we were able to start sending invitation letters out to that group. What we also were able to do was to make sure that we did match the demand with the supply, and we were able to only send letters out to people who within a certain radius of a mass vaccination site. So it was either a 15-minute or a 30-minute drive. We are in receipt of all vaccination data, and almost as it's given in almost real time. There are several data capture tools which are out there in all of the vaccination settings. By integrating with the National Booking Service, by NIMS being part of an integration with that, we are able to make sure that when individuals have received their letter of invitation, they then can go on to the National Booking Service to try to book. The National Booking Service will look back into our solution to make sure that those individuals are actually eligible, and then they're offered a choice of sites in order to go to be vaccinated. We're able to use the data that we get on a sometimes hourly, but most often daily basis to drive up immunisation uptake and to inform both current and future planning. We're also able to support the COVID-19 status certification solution. So to go on to call and recall, our service has about 5 key elements to the delivery, and the next few slides will talk you through those elements of the service. So call and recall. Once we've received the instructions, so the rules about who we are going to be inviting, and that's based, as we've already talked about, on the guidance of JCVI and making sure that we align the demand with the capacity, we are then able to send either letters or text messages out to individuals inviting them to book their appointment. We are able to send reminder letters out to individuals who have not taken up their offer, and we are also able to invite people for both their first and their second dose. If we are inviting people for their second dose, we are also able to make sure that the time that is between doses is adhered to. Again, we have a service, an outbound telephone recall centre service that is able to make telephone calls to individuals who have not taken up their offer of a vaccine. Those telephone calls are targeted, and so we have people looking at the data every day, and we look at areas of poor uptake, we look at cohorts of poor uptake, and the recall centre can focus its calls on those areas of concern. The purpose of the call is to identify what the barriers to uptake might be, to do what they can to remove those barriers and to encourage uptake. And if successful, they're then able to, as part of that same call, go on and book an appointment for an individual. We have a team of individuals who are our regional immunisation support team, who are across all of England. So we have, they're across all of the 7 public health England, NHS England public health regions. Those support team are able to look at the data on a daily basis to identify where there is poor uptake. They feed that back to their regions to support operational delivery. They also feed back the intelligence that is gained from the outbound telephone centre in order to say what, to inform the regions about what individuals are saying about why they're not taking up their offer. And that enables and supports some targeted campaigns to drive up vaccination uptake. Our service is supported and underpinned by our IT solution. Our IT solution is named NIMS, the National Immunisation Management System. The system receives data from multiple sources so that it's always up to date with the latest vaccination position. We receive some of the examples of data we receive all of the demographic data for patients within England, patients registered with the GP practice in England. We receive the GP data for all of those individuals who have got an underlying health condition that puts them into the at-risk cohort. We receive all the vaccination event data from sites, including primary care networks, mass vaccination sites, secure settings, hospital trust. And importantly, we also receive data from the national booking service and local booking services, so that when we're sending out our invitation letters, we are not sending out invitation letters to people who have already got an appointment booked in the future. What we do, what this NIMS has inbuilt dashboards that have monitor vaccination delivery at a national, at a regional, local, right down to GP practice level. The geographic analysis enables the planning for optimal locations for specific settings, such as groups of GP practices or any regional system. We also provide a weekly insights report to the commissioners, and elements of that report also get shared with all of the regions. And that insight report that goes out to the national commissioners and to the regions informs about uptake, but it also talks about some of the key intelligence that we have been able to identify from the recall centre. So some of that softer intelligence. This is an example of the dashboard that shows the England overview for COVID vaccination uptake. It's quite small on this screen, but you'll be able to see that it is we can break it down by region. In the bottom half, you can break it down by cohort to show which of the cohorts are being immunised and what the uptake looks like. We're also able to drill down on this dashboard to look at even down to a GP practice level. The dashboard also is able to show uptake across areas of deprivation, sex, ethnicity and age band. This is an example of one of the pages in the insights report that goes to our commissioners on a weekly basis, and this was showing that nearly 28 million individuals had received their first vaccine and nearly 10 million had received their second vaccine. We had sent nearly 21.5 million invitations out to individuals to attend a mass vaccination site, and we'd made over 1.7 million phone calls to non-attendees to try to understand the barriers to uptake.
Hello, I'm Andrew Fenton, Transformation Director in the Strategy and Transformation team. And in the next few minutes, I'm going to be talking about the support that myself and colleagues have provided in the South East, and also my colleague Caroline Rowe will be talking about the support that's been provided to the South West programme. over the last 6 months. So about last September, the national programme was taking shape, as Sue has been describing, and obviously significant support that's been provided in that field around the call and recall service. But in addition, there's been significant support that's been provided through teams in the southeast and the southwest and across the region for programmes to develop the regional delivery and work closely with each of the integrated care systems. So looking at the scope of what we've worked on, this has involved a whole team of people in each area, and with really good support from analytics and GIS teams and other colleagues. And we've got a number of colleagues, of team members still working in the programmes in both Southeast and Southwest. So significant work to focus on the interface with the national programme, to engage with the national team, to understand the design and inform the design of the programme nationally back in last September and October, and also close engagement and communication with the integrated care systems across each region to support and work with those teams on the planning and mobilisation of the vaccine programme at a local and ICS level. So there's significant focus on that operational planning, and that included a lot of focus on logistics, on estates and sites planning, and getting ready for those sites to be going live at the beginning of December. A further factor was to focus on what we call the service model mix. That's the balance between the different service models, including hospital hubs, large vaccination centres, PCN sites, pharmacy sites, but also the roving mobile service model, and planning and understanding the numbers of people that would be needed to be vaccinated through each service model and the timing of that. So that involved significant demographic demand and supply modelling, and had to take account of the expected supply of vaccines over the weeks from the start of the vaccination programme at the beginning of December. Further element that we've been closely involved in both regions has been workforce planning. So that's involved supporting both the planning of the numbers that were needed of the different types, both clinical and non-clinical, but also being involved in supporting some of the recruitment processes and onboarding of staff. We were involved in setting up the regional vaccine operation centres. Those have a key role to focus on very sort of immediate and short-term operational planning requirements around communications, cascades, actions, resolutions, issues to do with supplies, for instance, and clinical incidents. We've been involved and supported the monitoring of uptake, and that has linked to some of the systems that Sue spoke about earlier, for example, NIMS, the National Immunisation Management System, and Foundry, and we've worked on analysis and performance data on take-up by cohort and by geography. And that then links also to a focus on vaccine inequalities and the take-up rate by geography, but particularly by different groups, including ethnic minority groups, and across different sort of social, demographic and deprivation issues. So that's been the range of work that we've been involved in supporting, which has been really significant, and there's been a lot of pressure on the programme, particularly in the early days, and as the programme went live in early December, and throughout December, January and February and beyond. And the challenges have included a lot of uncertainty and constant change, both in the design and planning stage, but also during the delivery phase. For example, the supply volumes have varied, and sometimes that's been at relatively short notice. And national policy has often shifted and changed fairly quickly. So, for example, originally primary care wasn't expected to be involved in the delivery of the vaccine programme. That changed in about October, and then needed very rapid work to link with the ICSs and their primary care teams to plan and support the mobilisation of primary care services. Other challenges included the different vaccines that have different characteristics. For example, Pfizer, that needs ultra-low freezing in storage, and then has to be used within 4 days once it's been brought out of ultra-low temperature. Vaccine supply I've mentioned, that has varied significantly, and as you may know, there's been some constrained supply, particularly in April, and that led to, for example, some staff and some services having to be temporarily suspended for a period of time. And finally, as mentioned earlier, significant challenges around vaccine inequalities, and that's ongoing, but some of the work that we've done and others, and a lot of the work that local teams have done, has focused on reaching out to communities and improving the uptake across the region. So that gives a summary of work with the South East. Going to hand over now to Caroline Rowe to talk about the focus of work in the South West, and also Sue Pratt later on in a minute will talk about some of the work in the Bob system, Bob ICS. Thank you.
Hello, I'm Caroline Rowe and I'm an Associate Director within Strategy and Transformation. Since April last year, I've been working for NHS England, particularly supporting the South West region. So it started with my work within the supply and equipment cell as part of the COVID incident. And then along with many others, one of the roles that I took up from September was as the workstream lead for the Southwest region for the COVID vaccination programme, specifically looking at estates, equipment, consumables and logistics. So a number of us have been working on this programme, and so therefore I wanted to outline some of the things that we've been doing in the Southwest, and particularly some of the nuances to do with our own particular geography. So as you know, the Southwest region is made up of 7 systems, and we also are quite geographically dispersed, and the infrastructure across many of the patches is not very good. We also have a remote island population on the Isles of Scilly, so again some very specific things that we needed to ensure that there was appropriate coverage for the whole network of vaccination centres. So to help us with that, the COVID vaccination team asked SCW's GIS team to actually help map the optimum locations of sites. And so that was done very much on looking at the cohort demographics and the travel times to make sure that particularly our 10 vaccination centres were set up in the right location. And then as the programme developed, we obviously moved into the mobilisation stage after planning and operational stage. And that included setting up a number of sites, making sure obviously that they were set up and ready to go. That meant that it was very much a multidisciplinary and multi-agency approach. We worked very closely with, particularly with the military, Public Health England, with our local resilience forum members, which obviously included fire and police, and third sector and a range of local authority and other organisations. And working collectively with all of our health organisations, we managed to obviously get these sites set up. A critical element of that is the work that our workforce team did, and very specifically they set up and mobilised a workforce bureau and made sure that there were multiple workforce supply routes, and actually the work that they did was phenomenal. They worked with a number of the systems to make sure that there was sufficient team members to be part of the vaccination team. If anything, actually we were oversubscribed. They also worked very closely with our military colleagues, and our military colleagues not only helped us to set up the actual locations themselves, but there were also some specific rapid mobilisation teams that would actually do vaccinations. And so the workforce team have used them to trial digital staff passports. So the workforce team in particular have done a huge amount of work. Many of the things that we've done within the Southwest were adopted nationally, so not just some of the standard operating procedures or SOPs for workforce, but I know within my own work stream, particularly for the movement of vaccines, etc., that we help to influence a number of those SOPs that are used nationally. Our other team members that also helped us, we obviously had a lot of support from our data and analytics team, so they're continuing to work on the programme now, particularly looking at uptake and performance data. There was a lot of work also around for our IT teams. So again, mobilising, we helped set up and make sure that there was connectivity, and also the kit and everything was rolled out. And then finally, we also had members that were part of the blended communications team, and again, they've helped to reach particularly seldom heard groups. So there was a lot of work done to ensure equality and uptake across targeted communities, not only with British, Asian and minority ethnic, but also looking very specifically at some of the populations that was appropriate for the Southwest. So our travelling, our Romani, our boating, and other communities. So really and truly, it was a great team effort. The programme itself, as Andrew has outlined, was very fast moving, and actually as team members, we did exactly what we're used to within SCW. We were resilient, extremely agile, very solution focused, and we were absolutely embedded to make sure that everything was working appropriately, and that we actually managed to get those injections into people's arms. So for the Southwest, by the end of March 2021, we had managed to ensure that 94% of first doses of the eligible cohorts, so cohorts 1 to 9, had had those first doses. And then as of today, then we're also now up to about 25% of the second doses. So a fantastic effort, and a real privilege to be able to be part of that programme. Thank you.
Hi, my name's Sue Bratt. I'm the Senior Communications and Engagement Manager at SCW, and I'm here to talk about the support we gave to Bob ICS during the COVID-19 pandemic, including the vaccination programme. SCW Communications team's key role was to provide support to 3 CCGs and 5 acute community trusts across Bob ICS, with the aim of providing clear and consistent COVID-19 messaging to the public and key stakeholders, such as local authorities, MPs, and frontline organisations. We were also acting as the key bridge between NHS England's regional and national comms teams, Bob Incident Coordination Centre, and latterly the vaccination programme. Clear communications are vital during a pandemic. We were having to operate under strict media and stakeholder protocols led by the national NHS media team. That meant no deviation from national scripts, local press statements or media opportunities had to be cleared regionally or nationally. Media and VIP visits to vaccination centres were tightly choreographed with the national team, and no national statistics could be used, whether for the numbers of people who were in hospital with COVID-19 or the numbers vaccinated, unless they were verified by the national team. For community, there have been some major challenges. We had to push all of our communications online and boost our social media presence, create huge volumes of dedicated local information online, as there was no national central resource to point to, and commute huge changes in NHS services. Alongside that, we were also having to push national campaigns such as the Help Us to Help You campaign to encourage people to get help the help they needed as people stayed away from hospitals and GPs. But perhaps the biggest challenge was the command and control of level 4 communications protocols, which, with the level of clearance involved, slowed down our response to the media, the public and stakeholders. That was never more apparent than when we were working on the vaccination programme, when the national team were incredibly risk averse to the point where we couldn't communicate what we were planning until sites were live, to the deep frustration of local authorities, MPs, public, and all those that we were working with to deliver that programme. But it has been, Van Tam would say, a game of two halves. The vaccination programme has given us something to celebrate, and working with the Bob vaccination delivery team, which Andrew was part of, we delivered the national communication strategy to build public confidence in the vaccine by showing as many people as we could being vaccinated. In Bob, we had some real media firsts. 92-year-old Brian Pinker getting his first AstraZeneca vaccine at OUH Hospital was beamed around the world. Professor Andrew Pollard, who steered the development of the Oxford AstraZeneca vaccine, did many national media opportunities for us, as well as taking the time to do staff webinars. National treasures like Prue Leith posed photos and tweeted to her followers after she had her jab at an Oxford GP surgery. And we hosted visits and media opportunities for Matt Hancock, Simon Stevens and local MPs.
Hello, I'm Cliff Mwando, the GIS Technical Manager within the SCW Geographic and Mapping Intelligence team. In the following few slides, I'll outline to you some of the key GIS activities undertaken to support the COVID-19 program and briefly illustrate some of the analytical tools and information products produced by the team. Hello, I'm Cliff Mwando, a technical manager within the SCW Geographic Intelligence and Mapping team. The team provides a wide range of mapping and analysis tools, largely for health service sector organizations and pharmaceutical industry customers. In the following slides, I will outline some of the key GIS activities undertaken to support the COVID-19 program and briefly illustrate some of the analytical tools and information product produced. The work delivered was both at regional level for Southwest, East and East of England regions, as well as national for the NHSE. Scope-wise, we delivered products that addressed vaccination site selection, site catchment coverage, optimum vaccination routes for housebound, and vaccination uptake reporting. The tools enabled such critical elements of the program as site planning, measuring accessibility of coverage, identifying patients to be served by each site for vaccination invitations, and now we have put together tools for vaccination uptake analysis across different regions and usable against different socio-economic variables. All was enabled through the capabilities of the GIS technology that brings together data sets such as on patients, proposed vaccination sites, service delivery boundaries, other reporting geographies such as LOSOA or service boundaries such as STPs to produce visual interactive maps and graphs, as well as operational dashboards that can account for the program rollout progress, such as the number of sites commissioned, vaccinations administered by location and by age cohorts as well. In site catchment analysis, modeling tools were used to establish optimum national vaccination site locations. From the initially picked sites, performing travel zone analysis demonstrated what coverage or any gaps of provision would be, best say on the 45-minute drive times. and how such provision changed as additional sites were brought up and which patients would be covered by such coverage. With the vaccination rollout, we received and processed and mapped anonymized patient lists from the IMS system. These were records which were very high-level data entries for each patient, comprising a unique random code, their respective postcode, age group, or any vulnerability indications. These records were then analyzed into what vaccination site each patient is allocated and subsequently used to generate lists for contacting the patients on what site to attend for their vaccine. As the vaccination extended to housebound patients, we modeled house-to-house routes for housebound vaccinations, where using anonymized patient spreadsheet information received from, say, GP centers, we create the map locations of those patients, providing back to the GP centers route lists which were created based on optimizing the distance covered to administer the vaccines, critical time windows for vaccine validity, as well as minimizing vaccine wastage. Similar routes were created for courier routing setup for the lump testing logistics. These were designed essentially to optimize the collection of samples and their respective delivery. In relation to vaccine uptake reporting, we have produced a very accessible vaccination uptake tool, vaccination uptake and analysis tool that combines, story narrative, easy navigation, statistical reporting, and interactive geographical visualization to show how vaccination to this point in a given region varies across different locations, various ethnic groups within varying deprivation levels, and such information, we believe, can be used for informing intervention strategies for addressing such inequalities. In the example showing on the screen at the moment, the London region is illustrated here as an example of concept. Navigation is by scrolling in the story narrative on the left. You can select desired themes on the tabs on the right or on the top, and you can also get additional information from the map elements by clicking and getting the pop-up records, which describe a lot more of what that geography is showing. The tool was developed on data sets derived from the IMS system, and essentially we had information such as whether a person has been vaccinated or not, the type of vaccine, the location where they are and where they got their vaccine, and whether it's the first dose or second dose. The data is then aggregated into reporting geographies, and we used here the lower super output areas as well as the middle layer super output areas to produce these highly impactful visual and graphical illustrations. From the analysis, the breakdown shows that with ethnicity at lower super output area geography level, plus the minority group breakdown, there is a very strong correlation of lower uptake in non-white ethnic groups. In terms of deprivation, again conducted at lower super output area geography, plus combining the index of multiple deprivation scores, the illustration also brings to fore that vaccine uptake has a correlation with higher levels of deprivation, with areas of low uptake being closely correlated with higher levels of deprivation. Any of these tools that have been shown here are highly adaptable and can be repeatable and can be extended to delivering such analytical capabilities to other areas as well. Thank you very much.